You know, when we partake in something that happens across various geographies, it's really important for us to hear these lessons that are unique to each one of the places where we do the work. But it's just as important to think about how some of the lessons might be common across the board. So we're now going to hear a synthesis of learnings across the 3 countries from Ms. Jen Castro. She is the Gender Integration Associate in EnCompass LLC, where she supports EnCompass's gender portfolio. She's currently supporting AIDSFree's GBV work under the Strengthening Police and Prison Comprehensive HIV Services activity in Tanzania, and she's the lead author of the AIDSFree GBVI synthesis support. Jen?
Hi everyone, I'm Jen Casto. We've already had a really great introduction to the GBVI and wonderful presentations from the panelists this morning. So I'll be presenting on the synthesis report. And the purpose of the synthesis report is to provide a global level overview of the GBVI, highlight successes from the country reports, identify contributions and lessons learned across the 3 countries, and highlight implications for future programming. So during this presentation, I'll talk about 3 things. The first is the GBVI's scope and reach. The second is lessons learned at both the country and the global levels. And the third is implications for future programming. So during this presentation, there's some quotes interspersed throughout that come from the report. And the first is from a U.S. government respondent who said that, quote, "I think the experience with the GBVI indicators helped us to create what is a better indicator for all of PEPFAR." So the GBVI indicators are presented here on this slide. There are 4 of them. The first is P12.5D, the number of people reached by an individual, small group, or community level intervention or service that explicitly addresses GBV and coercion. The second, P12.6D, is the number of GBV service encounters at a health facility. The third, P12.7D, is the percentage of health facilities with GBV and coercion services available. And the fourth is GEND-GBV, which is the number of people receiving post-GBV care. So these 4 indicators were required for the 3 GBVI countries and were optional for other PEPFAR countries. Indicator 12.5D predated the GBVI, while 6D and 7D were developed specifically for the initiative. One thing to note is that although the third indicator there, P12.7D, calls for the percentage of health facilities, the number of health facilities is actually reported on. So in the following slides, when you see this indicator, it's actually the number of health facilities providing GBV services, not the percentage, just a note. The first 3 indicators were part of PEPFAR's Next Generation indicators, which were then replaced in March 2015 when PEPFAR issued new indicators for monitoring, evaluation, and reporting. And these new indicators included GEN-GBV, which is the 4th indicator on the list. So during the first 2 years of the GBVI, which is fiscal year 2012 and 2013, the countries are reporting on P12.5D to count the number of individuals receiving GBV services, but this was replaced with GEN-GBV, which all GBVI partners were required to report on in 2014. And the development of this indicator was informed in part by the experiences of the GBVI in piloting the next generation indicators. And the intention of GEN-GBV was to count the number of individuals receiving post-GBV care specifically, instead of counting the number of individuals receiving more general GBV services or interventions. When looking at the scope and the reach of the GBVI, GBVI interventions and services reached more than 1.3 million people across the 3 countries over the course of the 3-year initiative. Clinic and community level services provided included GBV screening, post-GBV care, HIV post-exposure prophylaxis. In fiscal year 2012 and 2013, over 1.2 million people were reached with GBV services and interventions. And in fiscal year 2014, approximately an additional 76,000 individuals were reached with post-GBV care across the 3 countries. You can see the numbers are considerably lower for GEN-GBV. This is due in part to the scope of the indicator, which did not include the prevention interventions that would have been captured under 12.5D. GEN-GBV also had a higher threshold that required several types of GBV services to be made available and did not simply count routine GBV screening. Of the 1.2 million people reached with GBV interventions or services in 2012 and 2013, as reported under P12.5D, approximately 642,000 were women and 598,000 were men. And those reached under Gen GBV and who were provided with post-GBV care in 2014, approximately 54,000 were women and 22,000 were men. And I think that both of these indicators show that it is possible to reach large numbers of both women and men with GBV services or interventions. And it highlights the fact that not only is there a need for these services, but when these services are made available, both women and men will access them. So this table presents the indicator data by country. And it's clear that across all three countries, there were huge increases from 2012 to 2013. As Floriza mentioned in her presentation on Mozambique, she had a great quote in there. She talks about how there were little to no GBV services on the ground in many of these places at the beginning of the initiative. And the GBVI managed to increase the available services and reach both women and men in all three countries through the existing HIV platform. For example, the number of individuals reached with GBV interventions or services at the community level increased from approximately 273,000 in 2012 to 967,000 in 2013. Over the course of the GBVI, approximately 64,000 GBV service encounters took place at health facilities, and this number sharply increased in all three countries from 1,700 in 2012 to over 62,000 in 2013. The number of health facilities providing GBV services also increased from 205 in 2012 to 744 in 2013. And the GBVI indicator data really demonstrate that individuals can be reached with GBV interventions through the existing HIV platform. And starting up this type of integrated programming takes a lot of effort and extensive coordination, but I think that you can see the number of individuals reached in only 3 years really speaks to the value of integrating GBV prevention and response into existing HIV programs. There are also several lessons learned. I'll start with the lessons learned at the country level. Although the 3 GBVI countries were contextually very different in terms of GBV and HIV prevalence and patterns, socioeconomic context, and security status, many of the GBVI's achievements and lessons learned were consistent among them and can also be applied to other regions and efforts to prevent and respond to GBV and HIV programs globally. So the country-level lessons fall into 3 categories. The first is coordination and collaboration. The second is programming and service delivery. And the third is country ownership and sustainability. And looking at coordination and collaboration, several of the country presentations talked about how important this is. I think the first lesson learned is about the importance of creating a strategic national level master plan prior to program implementation. Kelsey referred to this in her presentation on Tanzania. This type of plan is extremely important because it sets clear roles and responsibilities for all stakeholders, maps out all partner locations, activities, and resources, and helps to avoid duplication and increase efficiency. As you could see, the GBVI had a number of partners, 19 partners in one of the countries, and this kind of approach was really successful in helping the GBVI build country-level commitment and coordination at the early stages of the initiative. Collaboration with a broad range of country stakeholders, especially the host country government, is necessary during project development to help ensure buy-in and sustainability. Organizing this early in the process helps to avoid miscommunication, identify programmatic gaps, share lessons learned, and develop collaborative solutions. If key stakeholders are not included in the development phase, it can lead to major challenges later on. A centralized communication plan is also needed to help keep programs on track and to ensure that all stakeholders are involved and informed throughout implementation. And the GBVI demonstrated that the stronger the multi-sectoral, multi-level synergies are, the easier it is to implement this type of integrated programming. And developing and strengthening these multi-sectoral synergies at all levels at the beginning of program implementation is key to integrating and strengthening GBV prevention and response in the existing HIV platform. Looking at lessons learned around programming and service delivery, capacity building and awareness are needed at all levels. Building clinical service provider capacity is important, obviously, for integrating GBV into HIV programs. But the GBVI's focus on training government officials, community and traditional leaders, and non-clinical service providers was also very critical. Those involved in policymaking, training, supervision, and community leadership also need training on GBV and HIV. And building this type of multi-sectoral capacity at all levels helps to create a more enabling environment in which clinical and other service providers can more effectively deliver GBV and HIV programming. Additionally, successful GBV prevention and response really happens at the local level, and it's necessary to engage a broad range of community stakeholders, especially men and boys, during implementation to help gain that essential community buy-in and commitment. And the earlier presentations talked a lot about the links between community and clinical services. And by focusing on community level interventions and using existing community organizations and volunteers to carry out awareness raising and sensitization activities, GBV and HIV programs can achieve major gains even with limited resources. And in all the GBVI countries, community leaders and volunteers acted as extension agents and helped to roll out the initiative at the community level. It's also important to develop simple monitoring plans with consistent, targeted, realistic, and focused indicators that are aligned with government, donor, and implementing partner needs. Although different stakeholders definitely have different data needs, there should be a common GBV data collection system that is clear, suits both government and donor needs, and can be implemented by facilities and other stakeholders. And this type of collaboration is very time intensive, but a lack of harmony, especially among indicators, can create confusion about what is supposed to be reported and jeopardize the validity of information, which can ultimately limit the ability of stakeholders to use the data they've collected to improve programming in the long run. And finally, looking at country ownership and sustainability, using a phased approach and an iterative process to roll out programming can help to gain commitment from the local government and stakeholders. Rolling out programming too quickly can result in too many activities being developed and implemented at the same time, and the tension between activity quantity and quality was a challenge throughout the GBVI. And funding should allow for planning and piloting of materials, implementation with assigned targets in a staged format. And this approach can help to ensure quality and sustainability across programming. Integrating GBV into the standard health package can also increase sustainability. The methods that the GBVI use to integrate GBV prevention and response into the HIV platform can be applied to other potential points of entry across the health system to increase the number of individuals accessing GBV services. Harmonizing GBV and HIV prevention and response efforts with local government structures can also help to increase sustainability. Engaging governments at all levels in program and protocol design is really essential, and this may slow down the startup phase, but ultimately this type of coordination is needed, and GBV and HIV programs really need to align with existing government systems. There were several lessons also learned at the global level. The first is that political will and commitment by leadership is really key for the success of an interagency initiative like the GBVI. So the GBVI involved 4 different government agencies, 3 different countries across 3 years, and it was strong leadership, especially on the part of PEPFAR and the Gender Technical Working Group, that helped to see this initiative through successfully. Secondly, the decentralized funding facilitated the success of the GBVI model. This allowed PEPFAR country teams to build capacity and autonomy within their own context. It allowed them to shape programming for their specific countries, integrate GBV into existing HIV programs, and disseminate funds to implementing partners without having to coordinate incremental funding with contracting officers or representatives. Establishing a baseline and understanding the country context at the beginning are also important steps for a multi-country initiative. Although all 3 of these countries are in sub-Saharan Africa, they all have very different challenges and opportunities when it comes to addressing GBV and HIV. Data collection was also a challenge across the GBVI countries. A centralized plan and structure established at the outset for identifying indicators and collecting and rolling up data from all countries to the global level and back again to the country level is really needed. PEPFAR is aspiring to this data collection structure, which in conjunction in conjunction with simple, harmonized data collection tools, can help to ensure that data are collected, analyzed, and reported to the global level, where most importantly, they can be synthesized and rolled back out to the country level and shared with those who are implementing on the ground. As stated by one of the GBVI's implementing partners, one of the GBVI's biggest contributions was to show that this work is possible, that something can be done about GBV. So what does this mean for future programming? PEPFAR 3.0 is focused on increasing the number of people on treatment to the point where the burden of the HIV epidemic is lowered to where it is manageable for country governments, both in terms of capacity and financing. PEPFAR funding has plateaued, however, and is expected to remain flat. And if PEPFAR wants to achieve the biggest impacts for its investment, especially for gender equality and gender-based violence attributions, an integrated response to GBV and HIV can be applied to help ensure maximum impact, even with very limited resources. In looking at sustainability, this funding plateau means that resources will also need to be directed at those countries that are most committed to ending GBV and HIV and who will take on responsibility for programming and implementation in the long run. The GBVI's lessons on promoting country ownership and engagement can be applied to help prepare governments for this transition by working in partnership, allowing countries to help define priorities, take the lead on implementation, and develop the policy changes necessary to stop the spread of HIV. The GBVI's efforts also to establish community linkages can be adapted to help ensure sustainability of future PEPFAR programming by building local capacity to take on integrated GBV and HIV prevention and response. The current push to focus on HIV testing and treatment offers a really excellent entry point for GBV screening and service provision moving forward. In terms of priority populations, the GBVI successfully developed and promoted GBV and HIV service entry points across communities at schools, police desks, community-based organizations, and these types of alternative entry points are really crucial for identifying and providing services to individuals, especially priority populations who may not be regularly accessing clinical services. Many of those interviewed for this review also saw the GBVI as a precursor for the DREAMS initiative, which is the $385 million partnership to reduce HIV infection among adolescent girls and young women in sub-Saharan Africa. And many respondents believe that this initiative would not have come about without the existence of the GBVI. And finally, looking at GBV and HIV integration, this was the biggest lesson learned, that it is possible to integrate GBV prevention and response into existing HIV programs. And it's clear that this integration will be a key factor in achieving epidemic control moving forward. The links between GBV and HIV are well established, and the lessons of the GBVI can be applied to future PEPFAR interventions. This integrated approach really has the potential to help PEPFAR investments address GBV and achieve greater impact in preventing and controlling the HIV epidemic moving forward. And finally, I'm going to end with a quote that Elizabeth used, but it's so good that I'm going to say it again. It was the first time the donor had asked us to make a link between HIV and violence. For me, it was a priest to conscience, a starting point, and I began to really understand more in depth what these links are about and that we should talk about these links every time, not as separate things. And I think that really sums up the GBVI and its contributions in helping people to think about and address the links between GBV and HIV. Thank you.